So first, I would like to thank you, all of you, for inviting me for this webinar. I hope that my information be useful for all of you. Nowadays, I'm a LSO at Brasil for Collection, and the idea today is to share these 3 topics about the Brazilian PV system with you. So I will cover Brazilian PV structure, current Brazilian PV system, and some considerations. I bring this timeline to show you that Brazilian PV system is young. Our health system, called SUS, was structured, in fact, in 1998, as we have nowadays. And our federal health authority, which is Anvisa, was created in 1999. In 2001, Anvisa was appointed as Medicine Monitoring National Center and member of WHO PIDM. In 2009, we have our first specific PV legislation, and here you see the numbers of the legislation that we had. In 2016, Anvisa became an ICH member, and because of that, we changed a little bit our local legislation in order to be aligned with ICH guidelines. And 2018, Anvisa update this our local legislation in order to be more aligned, like I said, and published it for public discussion. And in the same moment, Anvisa adopted VigiFlow as a national PV database. In fact, Anvisa decided to adopt the VigiFlow, but changed the name to be more acceptable in Brazil environment. So we have VigiFlow, called VigiMed in Brazil. In 2020, to be more specific, some days ago, Anvisa published this new legislation and it became effective. PV system in Brazil is decentralized. Anvisa acts at a federal level with the highest hierarchical. PNI is the immunization national program, acts at a federal level also, but with focus in vaccine. And especially in São Paulo, you have the health surveillance unit called CVS, which is responsible for receiving and collecting ICSRs from market authorization holders, healthcare professionals, and general public based in São Paulo. So basically, this public here, these stakeholders, provide information to CVS, and CVS make this information available to Anvisa. We have Anvisa receiving ICSRs directly from healthcare services, healthcare professionals, and general public for other states. And the Immunization National Program receive cases from public and private vaccine units. PNI and CVS have their own PV databases, and unfortunately, at least at this moment, these databases don't have interface with Anvisa database. So this information that you see that they received here, of course, it's communicated to Anvisa, not by database transmission, but they are communicated. So despite Notivisa be the federal database, the ICSRs are not centralized there. Talking about database, as you can see in this slide, you have different databases nowadays in Brazil. So the first database that we have is the PeriWeb, the name of the database that was launched in 2005. This database is managed by CVS, that means the State Health Surveillance System. And in the PeriWeb, the Pharmacovigilance is established there for São Paulo State, and market authorization holders based in São Paulo and public from São Paulo City are obliged to submit the cases to PeriWeb, and like I said in the previous slide, PeriWeb transmit the information to Notivisa, but not electronic submissions. So Notivisa is the database from Anvisa, it means the federal database. It's a web-based system used especially by Sentinel Hospital and market authorizations and general public and healthcare professionals, not based in São Paulo City, and is managed by Anvisa. It was launched in 2007. And CIPNI is a web-based system used by public and private vaccine units. This system is managed by Immunization National Program, PNI, and it was launched in 2014. FormSUS is not a database, it's an electronic form used especially by clinical trials, but I included it here because some healthcare services also use this form to submit the information, the ICSRs, and this form is managed by Anvisa, and it was created in 2017. And in 2018, Anvisa, like I said in the previous slide, adopted VigiFlow and renamed it to VigiMed. So as you know, VigiMed is a web-based system. The idea is to replace it for Notivisa for it. And Anvisa idea is to unify the collect of ICSRs from different hierarchical levels in the system, at least for drugs. So now we are in a transition period from Notivisa to VigiMed. And it's important to say to you that VigiMed will be a unique database for medicines. So maybe Notivisa will ongoing for the other products, like, for example, devices and phytotherapics and the other types of medicine products. This paper that I bring to you evaluates Notivisa performance based in 8 attributes established by international guidelines. And the conclusion was that Notivisa has deficiency in 6 attributes. That is simplicity, so it's not easy to report a case in Notivisa. Acceptability, so of course, because it's not simple to use, people not accept very well to include the information there. Representativeness, it means that when you see the information inside Notivisa, there is no ICSR from different states in Brazil. Completedness, it means there is some fields that are not completed, that cannot be so useful for causality assessment. Consistency, that you can see, for example, similar fields with different information there, and timelines. So this paper shows us clearly that Notivisa was not the best system to represent a continental country like Brazil. Because of that, Anvisa decided to adopt VigiFlow. So VigiMed or VigiFlow was structured in 3 different hierarchical levels. So Anvisa has the highest hierarchical level with access to all system functionality and all ICSRs created by other levels. So the state health surveillance units have the immediate hierarchical below Anvisa, and considered as regional centers with access to their own ICSRs and local healthcare services. And the last level is the level that healthcare services, including hospital from Sentinel network, have, is the lowest hierarchical level, comprising healthcare units legally obliged to have a patient safety unit in their organizational structure. In addition to these three hierarchical levels, Anvisa put available the e-reporting module that is accessible through an open link in Anvisa's website. This model is targeted at a volunteer reporting by general public and healthcare professionals who are not linked to any healthcare services. With this, it's clear for you that Anvisa expects to receive cases from all population. It means healthcare professionals and non-healthcare professionals, and understand better how the adverse reactions works in our country. So this year, Anvisa team with UMC collaboration published this paper to evaluate the PV system performance after Vigimed implementation. As you can see in the chart, there are one increase in ICSR's numbers since the e-reporting in the blue bar was implemented. So it's visible here that we have an increase in ICSR collection. In this chart, you can see the number of ICSRs per month. So it's possible to compare 2018 and 2019. By Notivisa, so in the blue bar, you see the Notivisa ICSRs cases per month. And in the orange bar, you see the cases collected by Vigimed or Vigiflow. It's visible that Vigimed brought improvement in the ICSR's capture. In terms of reporter type, it's clear that in this chart that pharmacists are the main reporter, so you can see here. 7/8 of ICSRs in Vigimed were reported by pharmacists. It is a signal that it's necessary to improve training for other healthcare professionals. It was observed that 2 times more reporters from non-HCP compared with the same period before Vigimed. It seems that e-reporting tool is user-friendly system that contributes for improved ICSR's capture from non-healthcare professionals. So it's clear that this module is useful for our capture information from ICSRs. Unfortunately, Brazil doesn't have many studies in PV area. That is something that we need to improve in order to understand better the impact of AEs in our country and raising actions to prevent them. I included in this presentation some studies that will give us an idea about AE impact. One study conducted in 2018 about Brazilian PV system showed a notification rate of 36 notifications per million. It's show us that the notification in Brazil it's low than the other mature countries where the PV system is more mature. And it's clear that we have a sub-notification here. Another retrospective study review around 1,000 patients charged from hospital in the year of 2003 in Rio de Janeiro state, and it showed the following rates. One overall mortality rate of 80.5%, 2.5% of the cases are related to AEs, 2.3% of cases were related to preventable AEs. 34% of deaths were related to cases involving AEs. And 20.6 deaths occurred in cases whose AEs were considered preventable. So you can see here with this study that we need to invest more in understand the AEs in our country and the impacts to prevent this kind of data. A case control study analyzed a total of 57,000 hospital discharges from 3 Brazilian private hospitals of high complexity and with more than one quality certification between the years of 2002 and 2014, and found as result a rate of 4% of AEs. Mortality was 3.3 times higher in patients with AEs. So it's important data for us. Death cases were analyzed in Notivisa. It's another study. So they analyzed the death cases in Notivisa database from June 2014 and June 2016. And it was identified 417 deaths, the majority in adults and early population, so 85%. And the majority of notifications was from hospital, 97% of the records. It's not, it's expected since the Notivisa receives information in the majority of the cases from the sentinel hospitals in the database. So my final considerations. PV system integration is a point that you need to pay attention. It's necessary to invest in the system integration in order to centralize ICSR collection, especially in order to have a real scenario about AEs, impact, and raises actions in our country. Of course, we are in a transition time and where some state healthcare surveillance units, their own databases, and it can cause double ICSR submission, especially for the market authorization holders based in São Paulo. And the main point is that ICSRs are not centralized in a unique database that should be the federal one. Like you saw in the previous slides, you have sub-notification in our country. I understand that it's not a specific issue for Brazil, but I think you have much actions to be done in order to improve it. Anvisa, through VIGMED, was implemented, and it was a positive step in terms of simplification directions. And to capture ICSRs from general public that will be useful to improve the sub-notification in Brazil. However, additional initiatives would be necessary to reduce the sub-notification. Example, drug efforts in primary healthcare units and strategies to collect domiciliary ICSRs in this type of usage, especially regarding to OTC products. PV education and training, it's necessary to invest in training for HCPs and non-HCPs about PV. Like you said in the previous slide, the majority of cases nowadays are reported by pharmacists, so it's a great opportunity to collect ICSR's data from other healthcare professionals if you start investing in training. Include PV as a mandatory discipline in the universities. Unfortunately, you don't have this as a mandatory discipline. And stimulate PV cases discussion in healthcare services. And finally, you need to invest in PV studies in order to capture AEs in Brazil, you understand better the situation. Adverse events capture in Brazil is lower when you compare with other countries where the PV system is more mature. So it's necessary to have more studies, like I said, in PV area to understand the impact of AEs at our country level. Here's the reference that I bring in my presentation. Thank you for your attention. I hope that you enjoy and have a good webinar for all of you. Thank you.